We're very grateful indeed to Jenny Gray for having chaired the morning session, and it's my privilege to chair this afternoon session. We've got some very interesting reflections on approaches to intervention during the afternoon, and I'm going to start by giving just some brief comments about the challenge that faces us, because the challenge of eradicating child neglect is a very significant one, and we've heard a great deal this morning about the obstacles, about the difficulties, and about the tremendous amount of development for ourselves as practitioners, professionals, from our different perspectives, if we're going to actually make a difference. I think the NSPCC research shows very graphically that on the one hand, we have a change in the level of physical abuse and physical punishment, and some shift around sexual acts for children under the age of 16, but over the 10-year period, the level of neglect remains stubbornly the same. And we know that neglect and emotional abuse intertwined are the key aspects of what gives rise to the commission of abuse, physical or sexual abuse. It's interesting that from the NSPCC that reasons for contacting the helpline, Childline as was the helpline that the NSPCC now run, is neglect, is the commonest reason why children seek support, seek help. So again, the context of the neglect of neglect. The American figures, which are even more striking than our own in terms of the most prevalent forms of maltreatment. So there's no doubt that in trying to make a difference to the prevalence and the incidence of neglect, we have a major task on our hands. Mike this morning talked about the levels of prevention: primary prevention, universal, secondary prevention, targeted services for vulnerable families, vulnerable parents and children. We've heard a great deal about who are the vulnerable children, who are the vulnerable families, and then tertiary prevention, more specialist services. This excellent diagram from the key paper in 2009 from Harriet Macmillan, Jane Barlow, one of our speakers this afternoon, part of this group, used this approach to talk about prevention before recurrence, universal and targeted. The fact that when maltreatment of various kinds, emotional and neglect, continue, we have to try to prevent the recurrence of abuse, and we have to prevent the impairment that's associated to avoid long-term consequences. Been very, very helpful to hear this morning about the way in which we need to think about the triangle. We need to think about those children we know about. We need to think about the children that are known to many other agencies. And as Ruth Gilbert pointed out, there is this lower group, the self-report, so that the challenge to us to eradicate, to impact on neglect which occurs at so many different levels, involving so many practitioners, is such a challenge. So, and as Ruth pointed out, we need to see the overlapping, the small group of more seriously abused children and young people that come to note, and the way in which a healthcare practice deals with part, but a public health approach needs to encompass the whole context, the whole social context, and to address the sources of risk and the sources of processes which lead to harm to children. Our history in terms of research on really trying to make a difference at a population level is not great. We were fortunate that at our conference in November, Ron Prince, working with Matt Saunders, talked about the trial which was published by the Center for Disease Control in Atlanta, which utilized what Ron Prince described as a blended model focused around the use of the PPP parenting approach. And he talked about the importance of trying to blend together universal approaches where all parents in the target high needs area could be accessed, all parents of children with a defined problem, targeted approaches on the left, maltreating parents, offenders, parents living in poverty, single parents, mental health, which results in a tiered, multi-level system of parenting support. He described the Triple P system, which brought together media and communication strategies, brief advice, parenting skills training, focused parenting skills training, and intensive family intervention with a breadth of reach and practitioners being trained in this multi-tiered approach within the area. And the result of that was that the Triple P counties showed a lower rate of child out-of-home foster care placements, lower rates of hospital-treated maltreatment injuries, and the slower growth of substantiated maltreatment. This was a massive intervention with some evidence of response. But there are very few, as it were, statewide or major interventions to really try to make a difference. I think it's not that we're short of interventions. Bruce Chorpita, who we've worked with and who again spoke in November, identified 395 evidence-based protocols in providing intervention to prevent child mental health difficulties, 750 non-pharmacological treatments tested in controlled clinical trials. The work which I'm going to address a little later this afternoon, we distilled the common elements from 40 interventions. We're not short of interventions. But in terms of application in a broad enough field, we lack that evidence. I think we've been very fortunate that one of the approaches, and I'm pleased that colleagues from the NSPCC Neglect Project are here, because they are trialling the home-based, safe care, home-based services model with parents and child protective services, which was published last year. And this is based on a home intervention approach, which has been around for some years, but has never been adequately tested on a major population base. So the home-based programs serve thousands of families in the US child protection services. Neglect, as I've said, is the dominant maltreatment type. And as they comment, there's very little intervention science devoted to neglect. This is basically the only major study which has focused purely on neglect and has demonstrated a significant effect. As they comment, neglect recidivism is high and difficult to lower. Home-based neglect services have yielded discouraging findings to date. Evidence for effectiveness has been weak. The Safe Care Project 12 Ways is a home-based treatment of parents and child protection services specifically focused on child neglect, based on a structural behavioral skills program. Focus is on concrete caregiving, household management, improving parenting skills, direct intervention. Research since 1979, this has been going for a long time, has suggested a promising model, not tested in a scaled-up field implementation until the current study. It involves direct practice observation, in vivo coaching, potentially a helpful strategy compared to standard supervision. The current study tested safe care versus home-based services as usual, comparing coached versus uncoached quality control. They were comparable. Commonalities: the home-based format, service duration 6 months, weekly visits, reporting, use of assessment tools, support funding, training, basic elements, motivational interviews, targeting domestic violence, safety planning, and emergency funds were available, which I suspect in North America is quite an exception. There were over 2,000 families which were involved in the trial. Structured behavioral, parent-child or parent-infant interaction, basic caregiving structures, home safety, child health, provided as a component of a broader home visiting service. There was training for the team in workshops, life skills, role plays. Preschool-age children were involved. There were no untreated substance abuse disorders. Children up to 12 were served in addition. Services as usual, same type, same dose of service, comparable goals. Less structured, more discussion-oriented manner of intervention. Coaching was given to both. The main effect was that safe care was found to be better for preschool children, not so good for older children, also in favor of coaching. Compliance was high for both approaches. The home-based approach obviously had quite an impact. Treatment compliers in general had lower recidivism, and that didn't affect the treatment effects. And you can see here that this is a chart which followed these children for 7 years. This was a very significant follow-up, and having heard from Elaine about the very concerning long-term impacts of intervention, it's very important to see that there is one intervention which consistently, on a state basis, does make a significant difference in the field of neglect. And we'll be very interested to hear how the NSP application of this approach works in the longer term. We're looking forward to hearing how it works here in the UK. At Child and Family Training, our approach to how can we make a difference on a large scale has been to provide training on evidence-based assessment tools for social workers and allied professionals. And the current work we're doing, part of the conference today, is on the Improved Outcomes for Children, Young People and Families initiative. The aims of our project is to increase the use of robust, evidence-based tools for assessment, analysis, and interventions more likely to protect children, to improve frontline child protection practice, and to cascade training through an agency-based trainer approach. And the last support we had from the Department for Education was just to do that. So it means that we have trained over 40 plus agency-based trainers to actually train the tools that we've introduced on parenting and family intervention and child protection decision-making, and hopefully on the intervention model we're going to talk about, to see whether this can make a difference to practitioners. I'm very pleased that we still have the assessment framework available for us to use, because in my view, one of the factors which I think has made a difference over recent years has been the adoption of an approach which makes us think about how child's developmental needs are being met, how the parenting capacity helps meet those needs, and how family and environmental factors impact on parenting. And as we'll see a little later, we have found that it's possible to develop and operationalize the framework in a valuable way to help practitioners really take an overview of the work they're doing with complex family situations. And in addition, we've advocated the need for thinking in terms of the stages of recognition, full assessment, looking at the nature of a level of harm and harmful effects to do a safeguarding analysis, decision-making, plan of intervention, and identifying outcomes and measures. So this is our contribution to what we hope can make a difference to practitioners in using evidence-based approaches, so that our training program, our national training program, continues to include assessing parenting and family life, families in complex childcare cases, communicating with children, child protection, decision-making, the SAFE, using attachment-style interviews in childcare, and the Hope for Children and Families targeting abusive and neglectful parenting and its impairments in health and development, which I'm going to talk about a little later. So that in summary, to eradicate neglect requires a public health approach with interventions at primary, secondary, and tertiary levels. And these interventions should be informed by the wealth of evidence available, and I don't think anybody here could be unconvinced from the evidence that we heard this morning about what works and what doesn't work in our current practice. I hope that a common elements approach will help practitioners be able to impact and to intervene helpfully with children, with parents, and with family context. And it needs a political commitment to policy making using these approaches to support professionals' ongoing work to develop systems to eradicate neglect.